Hey, thank you for coming out today, and I hope that this will be, in one sense, a life-saving morning for you to hear from some experts in the field that address that higher risk of post-transplant cancer that I just was talking about before the meeting started. And again, in summary, before we start, so it's on the recording, the key is, one, to understand that higher risk, which comes mainly from the immune suppressant meds you have, but many other things too. Secondly, to watch out for the symptoms and do the preventative testing that they're telling you about. And third, don't ignore those symptoms. Go get them addressed. All cancers that we found, well, most, can be cured if addressed early enough. And if they're not addressed early enough, they can be fatal, even skin cancer. So by all means. And with that, let me just welcome you on behalf of Second Chance Heart Transplant Support Group. This is Jim Bullard on the right. He's the chairman of our organization. We have 4 chapters in the various hospital heart transplant programs here in the city, and we are the hub chapter. It is amazing today how many people are out more than 20 years. I asked Sally if she could find, they don't know offhand. I'm going to check with Eunice and see. The heart transplant process has gotten so good, but more importantly, the care after it. And the opportunities like today to come out and learn so you can live longer. This is back in 2009. I must admit I need to update this picture. But these were people who were out more than 20 years, and only 7 of them attended that dinner dance at the time. There was over 20. Now that's 7 years ago. Most of these people, as far as I know, are still alive and well. And so the real challenge you have, right, figure out what you're going to do with those many years of life. Yeah, there's averages, but every one of you beats an average. So keep that in mind. I met a guy just last year down in Trio, Maryland, an educational event in Baltimore, Orlando DeFelice. I went over and asked how long you've been out. 33 years. Now, 20 years is impressive. 33 years is very different because that was 1983. Does anybody tell me what happened in 1983? It's so important to all of us.
Oh, cyclosporin.
Cyclosporin was not invented, it was discovered. Okay, and that became the modern era of immune suppression drugs. And so I got to be honest with you, he's one of those early experimental situations, right? Most programs, they did what they did, patients survived, we kept doing it. If it didn't work, they changed something. The difference between our meds today and the care we get today is so different than it was 3+ decades ago. And so as I was introducing just before, why this topic today actually goes back to a meeting I had with Melinda, where we had her come speak about post-transplant cancer, which is a subject that I'll give you more information about later. But as I said before, most patients forget or don't know about the higher risk, so they don't pay attention to it. Second, studies have shown it's the second most common cause of death post-transplant. Recognized and treated early, most cancers are curable. And so that's why we're here today, to give you that education so you can identify them, get them treated, and cured. And so our panelists today, you've read this on the flyer, but what I want to do is just refresh what they're going to speak about. So Dr. Ford McLean will speak about the different types of cancer which post-transplant patients are at risk and how we screen for those cancers. And that's the research area that she works in. Chris Miller, I talked about just before, a legend in the field, and I say that because I've heard that even outside of here. Dr. Miller states that when diagnosed and treated early, skin cancer is curable. Regular examination of the entire surface of the skin is a key aspect of skin cancer surveillance. When I came to him for that first appointment, I was surprised when he said, take off all your clothes. I mean, that early dermatologist, where do you want me to look?
I'm lonely, Jim. Another indication of how lonely I am.
He will teach us how to spot precancers and skin cancers on the bodies in order to partner with a dermatologist so that the new, changing, and suspicious growth can be evaluated promptly. And then finally, do we have our third speaker here?
She's operating, and she'll be here.
All right. How do you pronounce her first name?
Thuzar.
Right. Dr. Shin is going to tell us solid organ transplant recipients are at increased risk for developing skin cancer, as high as 65 times that of the general population. She'll be discussing why transplant patients are more likely to develop skin cancer, what variables contribute to the increased risk, and what you can do to reduce your risk.
Good morning, everybody.
Good morning.
The last time I gave a talk like this, a few months ago, it was about an hour-long affair, and so I squeezed it down to about 15 minutes or so. At any point, feel free, to stop me if you have any questions. I'm happy to do my best to answer them. So, what I'm going to be talking about, for the most part, is heart transplant. However, what I'm saying about heart transplant goes for other transplants as well, because I heard that there were kidney transplant recipients in the audience as well. So, people in my family tell me that I'm really corny, but I liked, the heart of it. Smile for me, a little bit of a giggle, and then I can tell people that everybody else appreciated it as well. Can you guys hear me?
Yeah.
Yes. So there are many things that we are concerned about or worry about after transplant. And they include rejection. Your body doesn't recognize the new organ as self and wants to attack it, essentially. So therefore, we use a lot of immunosuppressive drugs to prevent that from happening and to prevent rejection. And in that process, we end up setting up our patients for things like infection, something else that we worry about. The immunosuppressive drugs also can lead to other unwanted consequences, including chronic kidney disease, hypertension, and diabetes. But what we're really talking about this morning is malignancy. So if you look at the data from the International Society for Heart and Lung Transplant, and I'll try to go over how we look at these graphs. So on the bottom here, you see that these are the number of years after transplant. And on the left-hand side, this is the percent of patients who are free from cancer. So up here is 100, no one has cancer. And then you can see that, as time goes along, from 1994 to 2013, very little difference. But by the time you reach out at 15 years or so, half of the people who have been transplanted have some sort of malignancy. Now, what types of malignancies do people get? What's not included in here is PTLD, which we'll talk about a little bit separately. But skin is a big contributor, as is lung cancer, and then there are several others. The most common, by far, is skin cancer, and particularly non-melanoma skin cancers like basal cell and squamous cell. And since we have two dermal oncologists here, I'm pretty much going to skip through this because they can talk about this a lot more intelligently than I can. This is a basal cell, more pearlescent, looks like it's reflecting light, and a squamous cell, a little bit more flat and crusted over. Basal cell is 10 times greater in transplant patients than in the general population, and squamous cell 100 times greater than in the general population. Of course, the most commonly affected areas are going to be head, neck, and arms, the sun-exposed places. They're also more common in individuals with fairer skin, but don't be fooled. People with darker skin get skin cancer as well. In the general population, there's much more basal cell versus squamous cell, but it's the opposite in the transplant population, more squamous cell than basal cell. And most commonly, they develop between 2 and 3 years of transplant, and lip cancers are more common in transplant patients as well. They tend to behave more aggressively. 5% of the transplant patients who develop skin cancer actually end up dying from it, as opposed to 1 to 2% in the general population. And the incidence of multiple cancers, up to dozens of cancers, is about 44%. If you take skin cancer, that is the basal cell and the squamous cell, out of it, there are many malignancies that you can develop after transplant. The most important of which, or the ones that we see most often after heart transplant will include lung cancer, PTLD or lymphoma, colon cancer, and then also breast cancer in women. So if you look at lung cancer, it's a chest x-ray, there's the heart over here, and then there's this here, it's not supposed to be here. Lung cancer among heart transplant patients is greater than in the general population. We know that in the general population, smoking matters a lot, but the greater prevalence in transplant is not due to people who were actively or who formerly smoked. And although that's true, you are at increased risk if you smoked prior to transplant. It increases with age, as it does in the general population, and it is the incidence is greater among men than women. And because the detection of this cancer usually occurs late, the prognosis can be pretty dismal. There's colon cancer. Colon cancer is relatively common in the population, and many of the common cancers such as breast and colon, cervical cancer, prostate cancer, you could have a situation where it's actually transmitted from the donor. If you look at colon cancer's survival, it's much lower in transplant patients than compared to those in the general population. There's PTLD. PTLD is linked to Epstein-Barr virus, and we know this better as infectious mononucleosis, things that you got in college, came in the sore throat, kissing disease, whatever we used to call it. We know that this is associated with PTLD, and if you have a recipient that's EBV negative but receives an EBV positive organ, there's about anywhere from 25 to 50 times the increased risk of developing PTLD. Heart and lung transplant recipients, as opposed to kidney and liver transplant, have the highest risk of PTLD, and it can be associated with a large B-cell lymphoma. It is the most common cause of cancer-related death. Here's an example of a CAT scan and a PET scan of PTLD. It hides in the lymph nodes, and so here is the chest, these are the lungs, parts hiding in here, and these are lymph nodes that go along the vessels and the airways in the body, and so they light up on PET scan. So here are all the lymph nodes. This is another shot of this, but here this looks more normal to you because this is a person and you're cutting through the person. And these are the lungs. You have lymph nodes in your axilla, so underneath your arms and your neck. So this is an example of PTLD lighting up. What are the risk factors for cancer after heart transplant? Age matters. So if you look at the age of the person at the time of diagnosis, most people are diagnosed for all of these cancers about around the age of 60 or so. You see there's a bigger spread with PTLD and lymphoma, but for the most part, people are diagnosed around the 6th decade of life. If you look at our data for the risk of cancer by age at heart transplant, so this is how old you are when you receive your heart. Here is freedom from any cancer, so there's no cancer up here, loads of cancer down here. And this is the number of years since heart transplant. You can see the younger people, even going out to 20 years, have less cancer. So less than, these are the age less than 50 folks versus the people who are greater than 60 when they are transplanted. And so again, the age at which you were transplanted matters. The number of years since transplant matters. In the beginning, from 0 to 5 years, most people don't develop a malignancy, but around the 5-year mark, going up to the 10 and 15-year mark is when you start to see these different types of cancers occur. Gender matters. So this is a look at a population in Belgium. This is the incidence of cancer, so more cancer as you go up and by the years of transplant. You can see that men have a higher risk of cancer than women do. And then if you look at race, so this is our data by race. This is the number of years since a heart transplant. You can see that people who are white tend to develop cancer more often than people who are non-white. So this should make a little bit of sense to you because it includes skin cancer, and people who are more who have a fairer complexion are going to be at increased risk of skin cancer. So if you take away skin cancer and look at this graph again, there is no difference. Okay? Whether or not you've had cancer in the past also matters. So again, this is the number of people who are free from malignancy. So as you go down, then you're more likely to have had a cancer. So those folks who have had malignancy in the past are much more likely to develop malignancy again, as opposed to those people who do not. And so these are large numbers of people that we're talking about. How long you're cured from a malignancy prior to transplant also matters. In a large study, we looked at folks who were cancer-free greater than 5 years, and they had the lowest risk of recurrence of their cancer, versus those who were cancer-free less than 12 months, and their survival was much less. So when we choose patients that we're going to give organs to, this is the reason why we have that 5-year wait for most cancers, because we know that if 5-year wait for cure for most cancers, because we know that if we wait less time, then those patients have less survival. So the take-home points here, what are the greatest risk factors? Older age at the time of a heart transplant. Males are much more at risk than females. If you have a prior history of smoking, if you have a prior history of malignancy. And one of the things that I didn't talk about is the immunosuppression itself. The immunosuppression itself, which protects you from rejection, increases your risk of infection, but also increases your risk of malignancy. And so often, when we have patients who have a malignancy, one of the things that we do is decrease the amount of immunosuppression that they're on. So yes, people have a higher risk of malignancy. Malignancy is more common in folks who have had a transplant, but does it matter? And the answer to that is yes, it does matter. So this again is from the International Society of Heart and Lung Transplant. And this is looking at patients who have had a malignancy within 3 years of their transplant. And then the red line is no malignancy, and the green line is they've had a malignancy. And what we're looking at now is survival. Okay? So if you take the malignancy folks, you can say half of the people, if you draw a line at the 50% mark and then draw a line down, right, half of the people will have passed away in 6.5 years. Versus the people who didn't have a malignancy within 3 years, half of those people will survive until 11.5 years or so. So it actually does matter if you develop a malignancy, especially within 3 years of transplant. What type of malignancy matters? You see here again, there's no malignancy here, and you have survival of about a half-time survival, about 11 years. The skin malignancy is actually, it's not so bad to have because it's much more similar to this line versus a lymphoma or PTLD. The survival is much worse. If you look at all the other cancers that we could be talking about, renal cancer, here's the survival here. So not too bad, as opposed to lung cancer, where the survival is terrible. And then you have things that are in between, including lymphoma. Another look at more cancers, prostate cancer. People tend to survive from prostate cancer as opposed to colon cancer. So the type of cancer matters a lot. So, yes, people are more likely to develop cancers. People are more likely to die when they have developed these cancers. It's a problem. So, what do? The keys are always going to be to have the knowledge that you need, to educate yourselves, and sometimes your physicians who are taking care of you, to participate in screening and to participate in research when you have the opportunity, because that helps you and can help people in the future. So what do we do about screening? So these are all the cancers that are actually relatively common in the population, but common in post-transplant patients as well. Is breast and cervical cancer. So for breast cancer, we get mammograms at the age of 40, and then every year following up with your primary care provider or OB gynecologist, especially if there's a history of breast cancer. And the same is true for cervical cancer. You need annual surveillance. Skin cancer, at least an annual dermatological exam by a dermatologist. For colon cancer, a colonoscopy every 1 to 5 years based on what your pre-transplant result was or what your most recent result was. For prostate cancer, annual prostate specific antigen drawn by blood and a digital rectal exam if indicated. And of course, if it's abnormal, you go see a urologist. And lung cancer, annual chest x-ray or an annual chest CT in high-risk patients. So for lung cancer screening, we know that if we intervene early, if we know that it exists, then we can increase the survival. So here, we've actually changed our protocol of screening so that the high-risk patients, that is patients who are greater than 60 years old, or patients who have a prior history of smoking, or patients who have a prior history of a malignancy. We do chest CTs on those patients annually. And here you can see this is a chest CAT scan. This is the patient, we cut the patient in half, and they're actually lying down on their backs. And so here's the left lung, the right lung, and this should be a black area just like the others, but instead you see a tumor here. And this is another example, same chest x-ray, just everything is in white, and again, you can see it here. For PTLD is a tough one for us. It occurs in about 1 in 100 or 2 in 100. The onset is anywhere from months to years after transplant. And although we don't have a formal screening program here at Penn, we're working on one because it is a pretty important cancer. And as I showed you in the graphs that we were looking at, people can die of this, and so we have to be on top of it. The problem with screening for PTLD is that a lot of people are EBV positive in the first place, and not all of PTLD is EBV positive. So you could just take a person and every 6 months send them through a CAT scan or a PET scan and see if any of their lymph nodes light up. But the problem with doing that is that you expose someone to radiation. And so we have to pick and choose the people that we're going to do it with. And we still had to come up with the best protocol to do this, but for people who we think are at pretty high risk, especially people who have had it before, and people who are EBV positive, who were initially EBV negative, but had a donor who was EBV positive, we spent a lot of time thinking about those patients, especially when they come in with complaints. Screening, and I think this is the key, and it needs to be tailored to the individual and not a one-size-fits-all approach. Obviously, for example, if people have had a history of cancer before, you're going to pay more attention to those people. It's going to be based on the cancer type, how common the cancer is, when we expect the cancer to occur, how bad the cancer is in the setting of a transplant, the age of the patient, the gender of the patient, and things like EBV status or CMV status. So I'm going to stop here and talk about, essentially just outline everything that I've said, and hopefully give us a little bit more time for thoughts and questions at the end. So transplant recipients are 3 to 4 times more likely to develop cancer than the general population. A lot of that having to do with the immunosuppression that we use. And those that do get cancer face a much greater chance of dying from the disease. This is why this is so important. Skin, lung, and PTLD are the most common cancers that we see in this population. Risk factors are going to include age at transplant, time from transplant, gender, and having a prior malignancy. The medications that we use to treat rejection can have an impact on malignancy. Having a post-transplant malignancy can lead to poorer outcomes. They tend to be diagnosed pretty late, and that's a part of the poorer outcomes. And screening is the most important tool for diagnosis. So we're good, as medical professionals, but the key really lies with you. You should know this stuff. You should know what cancers you're going to be at risk for. You should take an active role in making sure that your screening is up to date and done appropriately. And this is not on the screen, but is important enough for me to come out of here and have you see it. Knowledge, education, and screening equals power for you as individuals, and especially as post-transplant folks. Thank you.
Thank you. Chris,